Hello, welcome to this video titled PEM Presentations, Illustrative Cases. My name's Gareth and I'm one of the Children's ED consultants here at Leicester. The purpose of this series of videos is to show you a series of common presentations that we tend to see, our bread and butter, so to speak, in Children's ED, and through that illustrate and suggest a clinical approach that you might want to consider or adopt, and to suggest management options and things to consider in some of the commoner presentations that we see. Also, it's an opportunity in each case to showcase the available resources and guidance that we can signpost you to in the course of your time with us. So when we're thinking about PEM, what makes it special? Obviously, the patterns of presentation and pathology that we tend to see differ from our adult colleagues. Our patients themselves differ in terms of size, anatomy and physiology. They also differ in terms of psychosocial development. Our patients tend to pose unique challenges with regard to assessment, investigation and management. And you, as our junior members of the team, often come to paediatric ED with a limited prior experience. Some of you haven't done paediatrics since medical school. And for various reasons, paediatric emergencies tend to be more emotive and affecting, both in terms of parents, carers, and the staff involved. But perhaps most crucially from my perspective, paediatric emergency medicine is the management of undifferentiated illness and injury. What that means is that we tend to see children who've been brought straight to the emergency department with a perceived emergency, and as a result they haven't been filtered, they haven't seen a previous healthcare professional, and what we're seeing could genuinely be anything. And it's important to remember that, especially when we're potentially seeing someone at an early stage of the development of their illness. So we have a suggested approach to every patient that you see, and that is to address these 5 domains. You won't always cover each of them in detail, but as long as you consider them, then you'll keep yourself and all of our patients safe. Now, paediatrics is often described as having a holistic approach, meaning all-encompassing or wide-ranging. And that means we consider our patients in relation to their parents and their carers and their interaction there, their siblings and wider family units. They may have an extended support network in terms of friends and family or social or spiritual groups. And they are also dependent on the geography and the socioeconomic setup that they are in, including the wider society as a whole. And we consider their presentation in those contexts because they all have an influence on outcomes. Equally holistically, we need to remember that we are the patient's advocate, and when they attend and when they're assessed by us and they're under our care, we need to act in their best interest so as to keep them safe. When taking a history in the paediatric patient in an emergency presentation, it's very often second-hand or even third-hand, which means it's been through a filtration process, it's being interpreted. And that's understandable. Sometimes dealing with a non-verbal child or a neonate, it's not unlike being a vet. And we're all trying to interpret various variations in cries and whistles and groans. But not always. And you need to be very careful not to be dismissive or belittling of the 8, 9, 10-year-old who is perfectly capable of articulating what they feel is wrong with them. Likewise, while parents and carers may not have attended medical school or have any healthcare training, they know their children, and you need to believe their concerns and never be dismissive. In terms of the structure of the history, there are additional headings and aspects that we need to consider of varying importance depending on where we're at in child development. The birth history tends to be more important in the neonate, for example, and less important in the 15-year-old who's punched a wall. Developmental history and achievement of milestones is important, and you need a working understanding of development. Likewise, you need an understanding of the UK immunisation schedule, as we vaccinate at certain ages and stages because of the prevalence of disease or the importance of not getting the disease at certain ages. We take a family history, which may be key in considering certain inherited disorders, autosomal recessive disorders, which become more prevalent in consanguineous families, and common conditions such as seizures, both febrile convulsions and epilepsies, can run in families. And finally, pay specific attention to the psychosocial aspects of childhood. As children transition psychosocially into young adults and beyond, it can be easy to make assumptions and overlook certain aspects of behaviour, particularly in mental health assessments. So we recommend things like the HEADS assessment, which, as an acronym, means different things on different websites, but from my perspective stands for home, education, alcohol, drugs, social, sexual and spiritual, and is an aid memoir to help me remember to ask for certain aspects of life in a young adult when I'm conducting a psychosocial assessment. Clinical examination is often opportunistic in our patient group. Observation is key, and you will get far more useful information standing at the doorway watching a child play and interact with people they trust than you will trying to force them into a 45-degree position on an examination couch. You need to understand yourself and develop an approach that works for you with children. And in the process of examining lots and lots of children, hopefully you'll be able to differentiate what is normal from what is abnormal. In terms of recommending a pattern of examination priorities, the ABCD ENTT approach is useful in terms of prioritizing, obviously, the airway, breathing and circulation in emergency presentations, but also then leaving uncomfortable or distressing parts of the examination, such as ears, nose and throat and the tummy, till last. Now, COVID-19 has brought about many changes to clinical practice, and one particular aspect we need to consider in children's examination is the examination of the throat. Now, with the possibility of transmission of the coronavirus, we have to reassess the utility of routinely looking in children's throats. And so now, more often than not, the default position is to not routinely examine a child's throat. If we think about a presentation of fever with a complaint of sore throat, with palpable cervical lymph nodes and no coryzal features, we can see from something like the fever pain score, which is used to help make the decision about antibiotics or not, that there is actually little to be gained by looking directly at the tonsils in these kinds of presentations. And we can thus afford to be more pragmatic. However, there will be clinical presentations where it becomes necessary to look in the mouth of the child, and all the while we have to ask ourselves, is it necessary? What do we anticipate that it will add to our assessment? Practical procedures are a frequent requirement in the emergency department setting, be it to definitively treat an injury or a clinical illness, or to further investigate and help rule in or rule out various presentations. In paediatrics, there is a higher requirement to appropriately stage manage any planned procedures. Proper preparation and planning with clear explanation to all involved, including the patient, the carer, and any helpers, is the key to success. It is crucial never to lie, in particular to the patient, as to painful procedures. And it is not only recommended but actively encouraged that you ask for help from teammates as they can definitely make your life easier and enhance the chances of success first time. The play team in particular can achieve levels of distraction and stability akin to ketamine sedation at times. We also have a range of other adjuncts such as local anesthetics topically, other distraction and sensory equipment, and, as alluded to, in the case of more painful or more prolonged practical procedures, we have access to procedural sedation techniques. While all of this may seem over the top, at all times it is our duty to minimize the distress we cause to the child, to act in their best interests, and ensure that procedures are well tolerated in case they are required again in the future. If you've never done a procedure before, ask yourself, is now the time to have a go? It may well be an appropriate opportunity for learning a new skill. The department, the wider staffing, may make it a valid educational opportunity for your training. However, this may be a time-critical intervention in a critically unwell child, in which case perhaps a more senior member of the team ought to do this one. It's absolutely fine to ask for help if you're not sure. As a final point in our approach to the patient presenting in children's ED, we need to think about safeguarding issues. Now, I'm not necessarily talking about the common forms of child abuse, and you will cover that in greater detail in other induction sessions, in your mandatory training and ongoing teaching programs. But in every presentation and case that you deal with, your job is to be vigilant, to think about safeguarding and potential forms of non-accidental injury or illness. And if you do think safeguarding, it is your duty to discuss it with a senior and share that information. Safeguarding is, in that regard, everyone's responsibility. So at this point in the video, it's useful to think of a few rules that we have in the department aimed at keeping our patients and our team safe. In that regard, all children under 1 year should be discussed with a senior, by which I mean an ST4+ in the department. All children under 3 months of age need to be reviewed by that senior, and all burns and fractures in children under 2 need a safeguarding referral on ice and a discussion with that senior. Medical patients especially require a full set of observations, ideally 30 minutes before they are discharged. Do not discharge any patient with abnormal physiology without a senior review. The senior may feel that it is safe to subsequently discharge them. And any patients attending with deliberate self-harm require a mental health assessment, and that's by our mental health triage team, and a safeguarding referral on ice. If this suggested approach generates any further questions, please get in touch. You might want to look at some of our local learning resources on the EM3 website, join Slack for our ongoing teaching, and look at some of our policies and guidelines on the UHL Insight website. We can also signpost you to various national resources. But putting it all together, hopefully this gives you a suggested framework to assess your next patient, either refreshing it if you're an old hand at paediatric emergency medicine, or giving you something to start from scratch with if this is your first foray into paediatric ED. Feel free to take this further, looking at nerve center and taking on a patient, or you might want to continue watching as we suggest a series of common presentations and things to think about. So welcome to case 1. Poppy has arrived in the department. She's 3 years of age and appears to be presenting with fever. She's been put into children's majors, location 10, and has a dynamic priority score of 3. The DPS allows us to prioritize the order in which we see children, and it's informed by a variety of reasons, including the observations, the POP score, and any clinical concerns or needs for time-critical interventions. A DPS of 2 needs to be seen ahead of a DPS of 3. A DPS of 1 realistically is already been seen by someone, and generally the 3s can be seen in time order. When we click on Poppy, we can see again that she's been coded with a presenting problem of fever, and when we look at her triage assessment notes, we can see the assessment nurse has written she's been unwell for 3 days with a fever, cough and vomiting. She's got a reduced oral intake and she's miserable. Mum is worried. There's no significant past medical history, family history, and no social worker, which is a question we ask routinely of all attendances. When we look at Poppy's initial observations, we can see that she's been assessed on the POP score, that she's scoring a 1. Her SATs are 100% in air. Her heart rate is 130, respiratory rate 28, temperature 38.6 degrees. Her capillary refill is good, less than 2 seconds. She's got a good blood pressure, no respiratory distress, and is alert, such that the assessing nurse has no concerns. And she has an initial blood sugar of 5.4. At this point, it's useful to introduce POPs in greater detail. The Paediatric Observation Priority Score is a locally developed acuity score that combines subjective and objective criteria into an overall score, and it's embedded in our departmental language, helps us summarize how unwell someone might be or how urgent their needs might be. The higher the score, the sicker they're likely to be. So if we turn to our suggested approach from the initial video, a holistic approach in Poppy's case may be inquiring as to what brings them to the ED. Why have they come specifically to children's ED as opposed to perhaps phoning 111 for advice or seeking an appointment with a GP? It may be that there are some wider issues. There are some specific ideas, concerns or expectations that have led mum to seek emergency care. Remember, the concept of emergency is relative, and we can't assume that this is a primary care presentation. It may be that mum has lost a previous child to meningococcal sepsis, that she treats fever or has a fear of fever above and beyond what you or I have. It may be that they have called 111 or have attended the GP and they've been sent to us as a referral of sorts. In paediatric emergency practice, our history needs to be the right balance of comprehensive and targeted, and that is not always easy. But in this case, we'll be thinking and asking about the duration of symptoms, looking for key features that might identify a particular illness, so coryzal features, a sore ear, sore throat, a cough, associated symptoms such as pain in a particular area or breathing difficulty. We want to specifically look at intake of food and fluid and output, as wet nappies, dirty nappies are a good indicator of hydration and general wellness. We might want to think about infectious contacts. Is there anything going around? Have they been anywhere? And then specifically we want to look at the red flags associated with serious illness in children, such as their level of activity, their conscious level, their colour and their tone. And then in terms of comprehensive aspects, we ask specifically about immunization status, where they're at in the program, any regular medicines, and crucially, any allergies to medicines or foods or other allergens. Our approach to clinical examination in children is different to adults, and that's born out of necessity. So we'll look specifically at their appearance, at their activity, and their physiology, bearing in mind the time that the observations were taken. Don't rely on them if they were last done an hour or two ago. Get an up-to-date set or do them yourself. When we're doing our A, B, C, D, E, and T approach, in this context we're looking at specifically a focus of infection as a cause for the fever. And I'd signpost you to some of my colleague Damien's videos, including the Look, Listen and Locate video that's available on the induction website. We're thinking, when we're assessing, top to toe, looking for serious causes of infection and the likely systems they'd be involved in. So meningitis, ear, nose and throat infections, respiratory infections, and so on. When considering practical procedures, there are two aspects. One is the administration of medications, and in that context, primarily we mean antipyretics. NICE guidelines are pretty clear about the role of antipyretics in the treatment of children with fever. Fundamentally, you want to make distressed children who are in pain or uncomfortable feel better, and so that's reasonable to treat fever with paracetamol and ibuprofen. But on the other hand, a well child who happens to be febrile will not come to harm as a result of the fever, and they do not need to have antipyretics to treat purely the number. Fever is the body's response to infection, and the child will not come to harm per se. In addition, the response to antipyretics can cause false reassurance, and just because the temperature and heart rate come down does not mean that the child is not septic or does not have a serious bacterial infection, so be cautious. When considering further investigations in the child with fever, we need to really think about why we're doing them and what we're looking for. Even non-invasive investigations like a clean catch urine can be time-consuming, particularly for the parents, and relatively complicated. And whilst a positive urine dip will indeed change your management or aid in your diagnosis, it might not be essential to be performed in the hospital environment. It might be useful to think about oral intake and formal fluid challenge as a kind of investigation. In the process of a formal fluid challenge, you can gauge the quantity of fluid over time that an unwell child can tolerate, whilst at the same time demonstrating their ability to tolerate oral intake and educating the parents in a suggested technique that they can continue at home. When we come to considering more invasive or potentially painful investigations, we really need to move away from the concept of routine or baseline investigations and ensure that we are being targeted and seeking to answer a clinical question. Unfortunately, in paediatrics, there really are very few truly diagnostic tests. Blood results can be interpreted in a variety of different ways and can often yield no more answers than your clinical examination and history taking. In truth, probably the most useful investigative tool in paediatric practice is time. And in the final aspect of our generic approach to the paediatric patient, is there a safeguarding element? And in this context, it's probably more about keeping the child safe. You may find yourself asking, do we need to admit this child? That may be for further investigation or definitive treatment that cannot be delivered at home. Or it may include that element of further observation to help determine what's going on. Also in paediatrics, the decision to admit often involves consideration of the time of day or night, the parents' and child's distance from hospital, and the level of parent or carer concern in the situation. If, however, you've determined that it's safe to discharge the patient, they need to have a full set of observations within 30 minutes of discharge. You need an appropriate safety net that the parents understand and agree with. It's useful to have an appropriate information leaflet to give the parents, and where necessary, an agreed follow-up opportunity, which may involve the GP or returning to the hospital. And finally, you need a good summary in the departure coding on Nerve Centre, which will then form the GP letter and inform them of what's happened on this attendance. At all points, if you're unsure, discuss with a senior to make sure that the right thing is done. In Poppy's case, it really does depend on what you find in your history and clinical assessment as to what you do next. But remember how we said that the diagnosis is not always immediately obvious. Fever, cough and vomiting are all very non-specific signs in paediatric emergency presentations, and you can be seeing someone at a very early stage in the evolution of their illness. But that's okay. It's okay to have no diagnosis or a broad differential diagnosis. It's arguably more harmful to force a diagnosis early when there isn't one. And that's where we introduce the concept of risk stratification, which is key in paediatric emergency assessment. In this context, it's about the risk stratification of likely serious bacterial infection or sepsis. And that's where the NICE guidelines for feverish illness in children come in particular their traffic light system for identifying the risk of serious illness. If all of Poppy's findings and parameters are in the green area, that's considered low risk. In which case, even if there's not an obvious focus to your eyes, it's likely that Poppy's suffering from a self-limiting viral infection, in which case home care with appropriate safety netting is appropriate. However, if you find any features in colour, activity, respiratory, circulation, hydration or other, in Poppy's case, that means there's potentially an intermediate risk of serious bacterial infection, and we may require a more senior review or even a specialist review depending on what you've found. We might consider more invasive investigations beyond a urine dip, including blood investigations for inflammatory markers, etc., or imaging. And we might be thinking about admitting them depending on what we find or depending on those other factors that we discussed. And then red's a little more straightforward. If we're finding red features, that's high risk. You need to be getting help. We'll be potentially resuscitating things as we find them and seeking to stabilize the patient. We might be moving them somewhere else in the department, and we'll almost certainly be admitting them on from ED. All the while we'll be thinking, could this be sepsis? In which case there are a number of time-critical interventions we need to complete. So at this point, we've considered an approach to the 3-year-old presenting with fever. If you've got any more questions about that sort of presentation, please get in touch. You might want to look locally at our PEM website pages on the EM3 website, get involved in the Slack teaching discussions, or look at some of the relevant guidelines on the Policies and Guideline website on Insight. Welcome to case number 2 in our Illustrative Cases series. The next patient is Gasper. He's a 3-year-old and he's been brought in to location 13 in children's majors. He's a DPS 2 and he appears to have presented with difficulty breathing. So already you might be thinking there's something going on in that he's got a higher priority and that he's been put in one of the 3 HDU locations in children's majors. Sure enough, when you look at the progress notes, you can see that he's been brought in by ambulance, having developed a cough and cold overnight. He's been found to be wheezy today and working hard when the paramedics arrive. He's had some previous admissions, you don't know what for yet, last winter. He's not on any regular medicines and has no allergies. In terms of his observations, you can see he's actually scoring a 3. His saturations are 95%, and he's got an increased respiratory rate at 50 breaths per minute. He's not febrile, and the initial assessor feels that he's got respiratory distress in the form of recession, and the nurse has a low-level concern about him. So taking our standard suggested approach, there is an opportunity to be holistic in considering why the patient's called 999. And that's an opportunity to explore what things panicked them or worried them enough to do so, because that's a pretty big deal generally. It may be that they didn't call 999 and called 111 for advice, and that in the process of that telephone assessment, an ambulance was dispatched to assess them. It's also worth noting that we have a local agreement with EMAS that any child under 2 assessed by paramedics needs to be brought either to us in ED or to an appropriate local healthcare setting for further assessment. Moving on to our history, we identify that he has in fact had previous wheezy episodes last winter and was admitted overnight on one occasion. He's never had to go to intensive care or to high dependency setting, which are independent risk factors for severity of illness, and he's only ever been wheezy with cough and coryzal illnesses. On examination, we're looking specifically at his appearance, his level of activity. We're looking at his physiological parameters, again bearing in mind when his observations were done, unless he's hooked up to a monitor at this point. And from a top-to-toe assessment, we might focus specifically on his work of breathing, the effectiveness of that breathing, and any associated sounds coming from his breathing. Are we hearing expiratory wheeze, which might suggest a degree of airways obstruction? Are we hearing inspiratory crackles, which might suggest secretions in the airways? Are we hearing both, which in certain circumstances may signpost to certain infections like bronchiolitis, although that's generally an illness of the under 1s? Are we hearing air entry? Is it equal? If we're not hearing air entry, that's a pretty big red flag. Now, the exact diagnosis can be really difficult in the preschool age group, and lower respiratory tract infections, pneumonias, viral or bacterial, asthma, viral wheeze, bronchiolitis, and even cardiac failure can all be clinically indistinguishable and to a certain extent can coexist, making this a really challenging age group. But all in all, depending on what you find, you're going to initiate some treatment and you're going to risk assess the severity of illness, like in everything else that presents to us. You may find examination features that help you consult specific guidance. For example, here, our wheeze guideline, if you find wheeze. And if not, you might involve a senior who, with a bit of extra experience, may help direct therapy. In this context, if you found wheeze, you might think about a trial of bronchodilators, and the emphasis here is on trial. Instead of hammering people with bronchodilators, we need to revisit after administering them to see if there's been any benefit, any improvement in the wheeze, any improvement in the work of breathing. In reviewing the response, if we feel there's improvement, we might carry on with this kind of therapy, but stretch the intervals or reduce the dose over time as the child gets better. Or if we feel the child is no better or getting worse, we might escalate the therapy, either in terms of increasing the level of bronchodilators and associated treatments, or questioning the diagnosis in the first place. Are we barking up the wrong tree? In an emergency setting where there are time-critical interventions and drugs to administer, we like grab boxes, and we have a host of grab boxes for a series of common presentations. The grab boxes can be found along with all other emergency equipment in the stacks to the side of the bedside in the HDU spaces 13, 14 and 15, as well as in Resus 1 to 4. If you think we are missing a particular grab box, let us know and we'll see if we can't develop it. Depending on your findings and response to treatment so far, there may be other considerations as you go further down narrowing your differential. There may be an indication for steroids, for example. There's a good evidence base in illnesses such as asthma exacerbations. There may be a need to arrange more formal outpatient follow-up in secondary care in somebody who keeps coming back with wheeze, to consider other diagnoses. All the time, if unsure, discuss with a senior. Ultimately, you may get to a point where it seems safe to discharge Gasper. In this case, in the context of wheezing, a marker for safety in this department is the ability to tolerate at least 3-4 hours between inhalers. which would be reasonable for parents and carers to continue in the home environment. If the patient demonstrates this level of safety in the department, it's an opportunity to reinforce good inhaler technique to provide a safety net of what to do if things get worse. And obviously discharge observations need to be done within 30 minutes of discharge, and your departure coding forms the GP letter informing them of what happened this attendance. And as a final safety measure, we like to use a printed wheeze or asthma action plan which guides patients and parents in their weaning process, gives some immediate advice on what to do in an emergency, and also evidences the advice that we have given. The pink copy tears off and goes in the hospital notes. Parents keep the white copy for themselves and give the yellow copy to the GP. So having gone through what is a very common presenting complaint in children's, hopefully it's given you some food for thought. If you have any more questions, please get in touch. If not, you might want to look at some of our internal guidelines or some of the wider open access medical education that we can signpost you to. Welcome to case 3. Now in this case, we're looking at a 4-year-old called Tom who's presented to children's minors. He's got a DPS of 3. When we click on him, we can see that they're querying a leg injury. And the presenting history is that he's been limping today since he's got up. And they think maybe his left leg is painful. Dad recalls him falling over yesterday, but at the time didn't think much of it. There's no significant past medical history. And Mum and Dad gave him some paracetamol at 9 AM before attending ED. Observations are pretty unremarkable. He's scoring a 0 on POPs. So how might our generic approach apply to Tom? Well, I won't labour the holistic aspect, but when we're thinking about the history of Tom's presentation, we need to consider, could there have been trauma? And it's important that we don't force a history of trauma where none exists. But at the same time, young children often fall over. It's difficult. Has there been any fever or recent intercurrent illness? Both of which feature heavily in children who can present with limp in the absence of trauma, due to things like transient synovitis. Have there been any other events that may account for limb pain? And these can be relatively simple or not memorable, such as sporting activities, increased activity, trampolining. Any associated features with the limb pain, so obvious things like redness, swelling, tenderness of joints, sometimes less obvious things such as rashes in other areas or other symptoms like headache or vomiting or urinary incontinence. Is there a significant past medical history both of systemic illnesses or of limb and musculoskeletal problems? And always, are there any red flags that might suggest a more serious systemic illness, such as weight loss, easy bruising, lumps and bumps? When it comes to examination, in standard kind of approach, we're going to be systematic but opportunistic. Don't forget a top-to-toe assessment, as gait abnormalities and limb problems can be manifestations of systemic illness. But ultimately, when we're dealing with painful limbs, we're going to look, we're going to feel, and we're going to move. All the while, we need to be opportunistic, and so as far as possible, we need to observe the child demonstrating what they can do themselves actively. You should be able to see a child's ability to weight bear and their gait just by observing them interacting with their carers, parents, people they trust. And then ultimately, when necessary, you are going to have to passively move for range of movement, and palpate for tenderness, effusions, etc. In which case do the good side first, the painful bit last, and wherever they are comfortable, be it standing or sitting on the couch or sitting on their parent's knee, you're just going to have to be opportunistic. And with the information that you get from your assessment, you might want to consult the Children's ED Limping Child Guideline, which exists purely to help risk stratify the likely causes depending on age, physiology and examination findings, to help us not to miss the rare but critically important serious illnesses that can present with limp, but at the same time not over-investigate the much more common self-limiting causes of limp. It's fair to say that the differential diagnosis of a limping child is very, very broad, but does sadly include some very serious underlying causes that we don't want to miss. Practical procedures may become necessary when assessing the child who presents with limp. Fundamentally, we must remember pain relief given early in generous amounts. We must also remember to reassess its effects and give more if necessary. Further investigations would be recommended as per the guidelines depending on your findings, and generally involves plain films, most commonly of the hips, blood tests looking for inflammatory markers, and crucially, time. When risk stratifying the patient in front of you, it may be reasonable to give that patient a few days and arrange to follow them up to determine which direction their symptoms and signs are heading. Putting it all together, you might determine that it's reasonable to discharge the patient, by which you're saying that they're able to mobilize, they have good range of movement, their pain is easily managed with simple analgesia, and there are no obvious red flags. In a lot of these children, our guideline would recommend that we arrange follow-up in a review clinic setting, which is currently housed in Fracture Clinic, in 2 to 5 days. This provides a welcome safety net in case a sinister pathology is evolving. If, however, it's felt that further investigation or management is needed on the day, that is done through orthopedic review and admission. So hopefully, this brief discussion of a child presenting with limp is useful in terms of getting you thinking about how you would approach it. If you have any questions, please get in touch. You might want to look at some of the guidelines I mentioned, such as the Limping Child Guideline, or at some of our learning resources online. Welcome to Case 4. So here we have baby Sunwell. We can see that baby Sunwell has been brought into Children's Majors location 14, and that there's a concern about fever. We can see that they've been given a DPS of 2, so a higher priority, and that their age is 0, which means less than 1. You could probably assume that they're less than 6 weeks because they're still called baby. Maybe not. We routinely give a higher priority to children under 3 months because they're at an enhanced risk of pretty much everything bad. But the fact that they've been brought through to location 14, which is the most resus-like of our 3 HDU spaces, may mean that that is in fact the case. When we look at the triage assessment, we can see they're in fact 12 days old, and they've been unwell only overnight with poor feeding, and they felt hot at home, not waking for feeds and increasingly lethargic. They last fed between 9 and 10 hours ago. They've got a background of being slightly preterm at 34 weeks gestation, and the assessment nurse has found them to be mottled and brought them straight through. When the observations are completed, we see that they're scoring a POPS of 10, Saturations are 92% in air, the heart rate is 188 and the respiratory rate is 70. They have a recorded temperature of 39.4 degrees and a prolonged capillary refill time of 3 to 4 seconds. There is evidence of respiratory distress in the form of recession, and they're only really responding to voice. The nurse is understandably very concerned, and they score also for having a background of prematurity. Blood sugar is also 2.9, which is borderline. So at this point in these videos, I will introduce the generic approach to the patient for you to consider. But obviously at this point we will hold that thought because this child is sick. So we're going to immediately identify this child as high risk and probably very sick with the potential for rapid deterioration. We're going to need to summon senior medical and nursing support by shouting, by pulling the emergency buzzer, or if needs be by tannoying for assistance from the wider floor. If we initiate a rapid assessment, prioritizing A, B, C, and then D, E, F, G, don't ever forget glucose. And as we find issues, we initiate resuscitation, all the time thinking, do you need more help? In terms of resuscitation, these scenarios can be stressful, and it's easy to forget that we are surrounded by helpful people and helpful equipment. Everything that you need to resuscitate this baby is around you in the HDU spaces, and you are only a few steps away from the emergency room. The pattern and priorities of our resuscitation are pretty generic. We start with a rapid primary assessment, A to E. As we find things, we resuscitate them there and then. Then we reassess. If we keep doing this in a cyclical way, eventually we will stabilize the patient and identify key features for which we can give targeted treatments. In this case, with a recorded fever in a 12-day-old, that would involve antibiotics and fluids, for example. As we give those emergency treatments and continually reassess, we ultimately will achieve stabilization and be able to transfer this patient to definitive care. Now we know children deteriorate quickly, and when they deteriorate or decompensate, it's often having been compensating for a prolonged period of time. In the case of the collapsing neonate, it's really helpful to always think about sepsis, cardiac or congenital heart disease, metabolic disorders and non-accidental injury, because they are the key causes of neonatal collapse. They also have quite similar presenting features and can even coexist. So again, while resuscitating and risk stratifying for the likely causes, if we cover these domains with antibiotics, careful fluid resuscitation, thinking about prostin or early cardiology input, doing a lactate and ammonia in addition to our other investigations, and thinking about NAI, then we dramatically improve our chances of successful treatment. So hopefully this brief discussion of an unwell neonate has generated some questions. If you have questions, please get in touch. Otherwise, you might want to look at some of our local learning resources and guidelines, or some of the signposts on our website to some national resources. Welcome to case number 5. In this case, we have Rosie. Rosie has been brought in to the emergency department with an apparent feeding problem. The initial triage assessment documentation says that she is 5 weeks old and that she's been vomiting feeds overnight. There's also something about her not using her left arm as much as the right arm. She has a background of being a term infant and the triage assessor has noted bruising to the forehead, which, when asked, the parent states that Rosie rolled out of a Moses basket a few days ago, but they didn't think much of it. Immediately, the triage nurse feels that something is not right about this presentation, although they can't really articulate what at this stage. Observations otherwise are pretty unremarkable. And so when it comes to their assessment, how might we utilize the generic approach that we discussed? Remember, a holistic approach is to assess the patient in the wider context of the environment around them. So that includes the parent and carers. That also includes their living conditions and environment. It includes the interaction that we witness between the parent and the patient. Any relevant previous attendances that are visible on nerve center. Any particular alerts visible on nerve center, including the Child Protection Information System alerts. And as we routinely ask, do the family have an allocated social worker, and if so, for what reason? When taking the history of the presenting complaint, it's important to explore any history that is offered in the context of whether it is compatible and whether it is credible. It's also worth noting whether it is fluid when it is reproduced. In this patient's context, it's entirely compatible and credible for a 5-week-old to be vomiting. And further history may better define the nature, timing, volume, associations, etc. of that vomiting. However, is it compatible for a 5-week-old to roll out of a Moses basket, to sustain bruising to their forehead? Is it credible that a 5-week-old is developmentally capable of rolling? No. Likewise, we would not expect a 5-week-old to be using one side more than the other. And so already a seemingly simple 5-week-old vomiting presentation has started to take a turn. With that in mind, while our examination needs to address a top-to-toe assessment looking for potential serious causes of, in this case, vomiting, we also need to be focusing equally on the patient's appearance, their level of activity, their physiology, and the specific areas that our nursing colleagues have drawn attention to in their assessment, whilst putting it all in the context of the developmental level of the child that you assess. And while good documentation is always important, that is even more true in this presentation. If evidence of external injury is identified, in particular in a mobile child or in areas that are difficult to explain by normal child behavior, it's always best to ask a senior for a second opinion. When we're thinking about practical procedures in this context, priority 1, if we've got a potential injury, is analgesia. And it's very easy to forget this in cases that take a safeguarding turn. Likewise, in the emergency setting, our priority is to identify and treat life and limb-threatening injuries. And whilst we may recognize safeguarding concerns, subsequent escalation and investigation is a multi-agency process and not left exclusively to the ED. It can be difficult, much more difficult in this case, but at this stage, having taken the history, having identified potential evidence of injury, and when dealing with very vague pointers in the history, including vomiting and poor feeding, it's really important to think to yourself and ask the question, could this be non-accidental injury? Do you have safeguarding concerns? Because if you do, you need to escalate them to a senior. That's all. This fictional case turns out to have evidence of subdural hematomas on an emergency CT scan that was performed after the baby was noticed to be fitting in the department. Further investigation showed multiple fractures of multiple bones in the upper limbs. This is an example of the need to remain vigilant for potential safeguarding problems in children, as so often a significantly injured non-mobile child is brought to the department with vague presenting complaints. Indicators that should be a cause of concern include problems in the fluency of the history or problems in the plausibility of what's being suggested, injury patterns themselves, especially in non-mobile infants, injuries or history that goes against the developmental capability of the child in front of you, any significant past medical history, specific risk factors such as looked after children, children subject to child protection plans, or severely disabled children. And it's a credit to the team that experience, sixth sense, alarm bells, gut feeling actually has a degree of evidence in terms of picking up when things don't quite feel right. In which case, the key is always to act on those feelings and share the information. Now going forward, you'll get more safeguarding education in your time with us, also in your mandatory training. But it's worthwhile remembering that we have a traffic light system for risk stratification in safeguarding, much like everything else. And safeguarding is not always about intentional injury. It's about risk stratifying the risk of harm. And that risk of harm can come from poor decisions and vulnerable situations just as much as inflicted injury. And the overarching important thing is to share information where you have concerns. So, having discussed a case of a potential non-accidental injury and associated considerations, it's a useful reminder that safeguarding is everybody's responsibility, and you don't need to make expert decisions, but your role in our department is as the child's advocate, to consider non-accidental injury and to be aware of the local processes, and always to share your concern by escalating to a senior. With that in mind, if you have any further questions, please do get in touch. You might want to look at some of our local learning resources on this topic and get involved in the teaching program on Slack.